you are up north. So my name is Michael Cheetham. I'm in the Insights team at North East London ICB. I'm going to be talking to you today about cost of medication and how people are paying for their prescriptions. If you think back, you all know this stuff, of course, but just to get you in the right headspace, in June, summer 2022, we were just coming out of the third wave of COVID. We had a whole bunch of economic shocks through COVID, severe recession, reduction in economic activity, particularly affecting certain bits of the population, people from low-paid jobs, people from ethnic minority backgrounds, people with disabilities, and people living in the most deprived areas were twice as likely to die than those in the least deprived. It's been a pretty bad time for lots of people. But unfortunately, Russia invaded Ukraine and we were straight into the cost of living crisis because gas prices went through the roof and inflation shot up. As an integrated care system serving about 2 million people, we were, of course, concerned about the impact of this on the population we served. So we had some workshops and pieces of investigation into what this might mean in practice. We were looking at things like the ability of people to heat their homes, afford to run medical devices, and their ability to buy over-the-counter medications to treat themselves, and their ability to pay for prescriptions. In June 22, the National Pharmacy Association ran a survey among their members, and they found that 68% reported an increase in the number of people choosing not to take prescriptions because of cost. So this tallied with some anecdotal evidence that filtered through to both us in the Insights team and the medicines optimization team from frontline clinicians in NEL, people sitting in UEC who were handing out medications that could have been a prescription, and people and pharmacists and GPs who were dispensing medications like paracetamol. Before I go into this any deeper, just a little bit of background around now. We're 2 million people, or some, depending on whether you believe the census or our own GP register, 2.5 million people in North East London, spending about £4 billion of public money. We've got a really ethnically diverse population. Over half of our population is not white, compared to about 85% the other way in the rest of England. We're younger than England and London in general, and more deprived. We're not the sixth most deprived local authority in England, and we don't get marked, but we do appear on Chartbooth's poverty maps. One thing that there's a lot of variation between the inner London boroughs of Tower Hamlets, New and Hackney, where it's very deprived, very ethnically diverse, and the outer London boroughs, Havering, Redbridge, where people are typically a bit older and quite often whiter. So in terms of just going back to the medications issue, there was lots of press about this at the time. One of the stories here on the right-hand side of the screen as you're looking at it is about Calpol being the most shoplifted item in one of our local authorities, Tower Hamlets, which is a bit of a shocker, really. And there's stories here about both the over-the-counter medication issue and the prescriptions one. The rest of the work I'm going to present is about how we developed evidence out of the data that we hold that there was a real issue around prescriptions. So when people get a prescription, they go to their doctor, they get a prescription. How that happens depends on whether it's an acute or repeat prescription, and then they'll go to the pharmacist and collect that. When you go to the pharmacy, about 90% of prescriptions dispensed in a community pharmacy are under one of the exemptions listed here. Broadly speaking, it's age. If you're over 60 or under 18, or under 16, and not just generally, you will not pay for your prescription. There's a whole list of medical conditions that exempt you from payment, and you're also exempted for maternity and for a small number of benefits tied to income. People who don't fall under one of these exemptions pay a charge which is currently £9.65. So we needed to look at this in the data that we hold. We needed to identify a group of people who pay for their prescriptions and a group of people who don't pay for their prescriptions, and compare what happens to them over the period of the cost of living crisis. So we looked at a number of different conditions to try and figure out what would be good, and we landed on looking at asthma because it's got a number of useful characteristics for this work. It can affect anyone. You can be 14 and have asthma, or you can be 75 and have asthma. It's quite often, not universally, but often present by itself without lots of complicating comorbidities which might change people's behaviour or how they control their health. It's pretty prevalent. We've got over 100,000 people in now who have asthma. And it's controlled by medication, so people need to take a puff of, or some puffs of the brown inhaler, the maintenance inhaler, on a daily basis, and people will often have reliever inhalers as well to control asthma attacks. You're picking up a lot of medication. It's quite tempting to not get the maintenance inhaler. The effects of not taking that won't be necessarily immediately obvious if you have pressure, which may be a cost pressure not to get it. So we have data from two sources on prescription. One is EPACT, which I imagine lots of people in the room will be familiar with, and the other is the Discovery database, which is an extract from our GP clinical systems, which is almost complete across now. The EPACT data is down at prescription level and does allow us to look directly at exemptions, but unfortunately it doesn't have any kind of data we can use to triangulate financial pressure on people. And we can't link it back to any of our other data sources to try and get that. Discovery data is very rich. We have demographic data there, we have IMD. The disadvantage of that is that we don't know whether a prescription has been issued or not. So we know that it's been prescribed, but we don't know that the person has picked it up. So what we did on this then, we take a little bit out. We used IMD from Discovery as a proxy for ability to pay. IMD is obviously a metric that is calculated on an area rather than an individual basis. So if you have someone in IMD 1, they could be a millionaire and have absolutely no problems with paying for their prescription. So it's a fuzzy metric for sure, but it was the best that we had at the time. The other thing about IMD is, if you go back and look at the definition, a part of it relates to benefits. So people with certain benefits will be exempt from prescription. So as you go down the IMD deciles, you'll have more exemptions coming in. So this gives us two groups, people who don't pay for a prescription and people who probably pay for a prescription. And we've got their ability to pay, kind of broadly speaking, there. And because these most deprived deciles are likely to have benefits related to that, we're expecting to see a big effect in this area here, not the very bottom of the IMD profile, but somewhere in the middle. So here we have a set of graphs for the people who don't pay for prescriptions. This is the over 60s. And there's a lot of graphs. We've got volume of prescribing up the y-axis. We've got time along the x-axis, two periods, a baseline period of pre-COVID, pre-cost of living, indicated by the blue line, a post-COVID and cost of living period indicated by the green line. The red line is just a trend line through data, and everywhere you see a black downward trend, that is a statistically significant downward trend over the indicated period. So broadly speaking, people who don't pay for their prescriptions they've got broadly speaking, stable use of maintenance inhalers over the 2 different periods. This is exactly the same set of graphs for people who probably do pay for their prescriptions. And here, if you look at deciles 2, deciles 3, deciles 4, deciles 5, you see those downward trends in maintenance inhaler prescribing during the period which we'd expect to see it. We don't see it in decile 1, which, as I said, we think relates back to the volume of benefits in that decile, and we do see it in some of the higher deciles, which not quite sure about, but in general, what we have here is a picture of people who do pay for prescriptions, reducing their use of maintenance inhalers. People who don't pay for prescriptions, definitely not. So what are we doing about it? Our medicines optimization team are working on the 2 parts of this problem, both OTC and prescription payments. Both have been agreed in principle by our business case assurance group. The former minor ailment scheme has been prioritised, so they're working on that now. I was providing data back to them earlier this week to support it. And then once that's in place, we'll move on to working for the prescription medication support. I don't quite know what that is going to look like. It may be provision of prepayment certificates or direct support, but that will come in time. Acknowledgements, people in now I've worked with, they wouldn't let me have their photos, so I could put them on the screen. Ada and Uche in particular in the medicines optimizations team provided lots of technical guidance on inhalers. Graham is our boss, so we have to mention him. And Ellen would have loved to have been here today, seeing lots of inequalities presentations, I think. If you want to talk to either of us about it, our email addresses are there. And I'm leaving now at the end of July, so Natasha's a safer long-term bet. Thank you.